Okay.
Definitely.
Good morning. Today we'll have a case discussion on peripheral nerve injury. Dr.
Morning, sir.
Please, you can start.
Okay, sir. Today I'm going
Yeah,
to
good morning.
present a clinical case history of a radial nerve injury. So the history, I'm going to present the history of a 40-year-old male who is a resident of Kolkata of West Bengal state, who is a daily wage worker who does writings for clients of advocates and in front of the courts. He was admitted on 30th of September and I examined the patient on 1st of October. So the chief complaints, the patient complains of inability to move the wrist and fingers of the right hand upwards since 6 months. The history of present illness, the patient was apparently normal 6 months ago when he sustained an injury to the right upper limb at the elbow following a fall from 8 feet height from the terrace of his home while cleaning the shades. He fell on his right elbow onto the floor. He was having excruciating pain at the elbow and also noticed a deformity in the elbow. The knuckle of the elbow was noted displaced backwards. Also, he noted his wrist of right hand is drooping down. He was taken to the hospital and after initial examination and imaging investigation, he was informed that his elbow joint was dislocated and one of the bones of the right forearm is fractured close to the elbow. Also, one of the vessel is injured. He was treated in the hospital with reduction of the joint and external fixation of the fracture and repair of the vessel. And the patient was treated with splints, electrical stimulation for the past 5 months. Initially, the splint was given, followed by physiotherapy after 2 weeks of splinting. Initially, he was not able to do his job, the writing, or mix the food, or to lift the food bolus to the mouth, or to lift any heavy object. But now, for the past 3 months, with this splintage and physiotherapy, he is able to do some of these jobs to some of extent, except lifting heavy objects and labor jobs. There is no history suggestive of any leprosy. Past history, patient is on aspirin and silastazole for past 6 months. After the repair of that vessel, he's aspirin and silastazole. No history of any other long-term medicine intake for diabetes, hypertension, or leprosy. Family history, no history of any leprosy in family members or no other relevant family history. Personal history is a daily wage worker, non-vegetarian. There is a limitation to perform the routine activities at mixing food, holding glasses. Normal bowel and bladder habits, no addiction, is married and 2 children, low socioeconomic status. Summary, a 40-year-old male patient who is a daily wage worker sustained injury to right elbow 6 months back after a fall from height. Now, for the past 6 months, he presented with inability to lift his arm, his wrist and fingers for the past 6 months.
Okay, the examination.
General examination, the patient is conscious, alert, cooperative, and oriented, moderately built and nourished with normal facies. Patient sitting with arm by the side, elbow in flexion, forearm pronated, and right wrist is kept in neutral position by lifting it with the left hand. Vitals, pulse rate 88 beats per minute with normal rate, rhythm, volume. vessel conditions with right radial pulse felt with decreased intensity compared to the left. BP 130 by 80 millimeters of mercury in left arm in sitting position. Respiratory rate 13 per minute. Febrile, there is no stigmata of leprosy. On local examination, the right wrist shows the wrist drop and the fingers show finger drop. Right elbow shows a linear hypertrophied hyperpigmented scar of size 6 centimeter in the anterior aspect of elbow, which was extended downwards for a length of 3 centimeter from its almost midpoint, which is non-tender to touch, non-itchy, supple to palpate. On the lateral aspect of left arm, above the lateral epicondyle, 2 scars of same features of size 0.5 into 0.5 centimeter noted, separated by a gap of 1 centimeter. Triceps power 5 by 5, triceps reflex present, biceps and brachioradialis power 5 by 5, and reflexes present. Wrist extension, mild extension was present.
Okay.
Extension at MC page, metacarpophalangeal joints are absent. He's able to make fist and hold objects, able to write in legible words. No wasting of any intrinsic or extrinsic muscles noted. No wasting of the forearm muscles noted. The circumference of forearm measured at 10 centimeter from olecranon process, both forearm, no wasting noted. No sensory loss or skin changes noted in the right upper limb. Radial, right radial pulse palpable, but feeble compared to left. So other system examinations within normal limits, except the CNS, except for the wrist drop and finger drop, loss of extension at the MCP joint at right end. So diagnosis, complete low injury of right-sided radial nerve secondary to trauma.
Okay. So in the diagnosis, you have to include the duration of the injury. That is 6
Yes, sir.
months. In
Duration, okay, sir.
duration of the injury you have to include.
Okay, sir.
That is 6 this case.
6 months.
Yeah, and more or less, I think, sir. What was the handedness of the patient?
Sir, he was right-handed.
You have mentioned it, no?
Oh, sorry, sir. I haven't mentioned it.
Yeah, in cases of any nerve palsy, especially in the hand or in the forearm where you are presenting, handedness, mentioning of the handedness is mandatory.
Yes, sir.
So in this case, you have told that the patient is he's a scribe, that is, he writes for any advocate
Yes, sir.
outside the court. So his hand function is very important for his occupation.
Yes, sir.
And he suffered from a fall, which resulted in both a vascular injury, probably the radial artery, the brachial
Sir,
artery
brachial
injury
artery.
above the elbow, and
Yes,
a open supracondylar fracture.
Sir, I have checked the X-rays. It was a radial head fracture and elbow posterior dislocation of elbow joint.
Okay. And also in your presentation, you have to mention the range of movement since the injury is quite significant.
Okay, sir.
What are the movements in the elbow joint?
Sir,
The
elbow
normal
joint,
movements.
sir, normal movements are present, sir, now. So
Yeah,
he
what
can,
are the movements
sir,
in the elbow
actually
joint?
flexion and extension,
Yeah.
pronation and supination, sir.
No, pronation doesn't occur in elbow joint.
Okay.
Yeah, so it occurs below the elbow, that is because the radial head fracture is there. So was there, so maybe there is some limitation in the what are the pronators of the elbow joint?
So,
Which muscle pronates the elbow
so
joint?
brachioradial.
You have mentioned that the pronation in the attitude of the patient, that the patient has a flexed
Which muscle
elbow
pronates the forearm?
Brachioradial.
and pronated forearm. You mentioned it in your presentation. Muscles are
Yes, sir.
pronator teres and
Brachioradialis.
pronator quadratus. Yeah. Brachioradialis is how you told that the brachyradialis was normal. So how did you examine the brachyradialis? How did you know that the brachyradialis is
Sir,
normal?
I asked the patient to flex the elbow joint against resistance with the arm in mid position.
Yeah. So in mid pronation, the brachyradialis is the prime flexor, and in supination, the biceps muscle is the prime flexor of the elbow joint.
No, sir.
So in this case, you have mentioned it is a low injury to the radial nerve.
No, sir.
So why is not a high injury? When will you call it to be a high injury?
Sir, in high injury, sir, I mentioned it low injury because the patient is there is a wrist drop and hand drop, and sir, in high injury, there will be sir, forgot, sir.
Which muscles will be
What is the
spared?
yeah,
Sir,
which muscles are spared if there's a low injury?
in low injury, sir, extensor carpi radialis.
Which are spared?
So triceps is spared.
Okay.
So
So
brachioradialis is spared.
brachyradialis is spared, and what are actually any
Tricep.
injury? Yeah, any injury which is below the spiral groove. If you follow the course of the radial nerve, there is a course along the bone, that is the
Spiral
along the
groove.
surface, surface of the humerus. So any injury
Humerus.
below the spiral groove is
Spiral
called a low injury. In this case, brachyradialis has recovered or was spared. So after the nerve comes out from the spiral groove, just at the when it is coming out, it supplies the brachyradialis, and just above the elbow joint, it supplies the extensor carpi radialis
Extensor
longus and
carpi
extensor
radialis
carpi
longus and
radialis
brevis.
brevis. So what is the function of ECRL and ECRB
Sir, meaning
normally?
extension, sir, extension at the wrist,
Which joint?
sir, wrist joint.
Wrist joint. So brachyradialis, the ECRL and ECRB, they take origin just above the elbow from the humerus and goes and inserts, that is the lower attachment is at the metacarpal bone, the extensor surface. So it extends the wrist joint. All the other extensor tendons, like the extensor digitorum as well as the
Extensor
extensor,
digitorum, extensor
yeah,
indicis.
they also cross the wrist joint, and while acting, they also extend the wrist joint, but the prime extensors of the wrist joint is the ECRL, ECRB, and the brachyradialis. So since there is a wrist drop, I'm not sure whether the brachyradialis has got adequate function, since the ECRL, ECRB is also not moving. So in this case, you have to do the MRC scale, that is how much is the strength. So how do you test a muscle power?
Sir, muscle power, sir, 0, there is no power. 1,
Okay.
there is a flickering of movement. Then 2, sir, along the gravity, the patient is able to move. 3, against the gravity. 4, against the gravity and with some extent of resistance, against some resistance. And 5, against resistance, like normal movement.
So in this case, what was your finding in extension of the wrist joint?
Sir,
How much power was there?
So the patient was able to, so mild extension was present, grade 2, 1 or 2, sir.
One will be flicker of contraction.
Sorry, 2, sir.
2 is when the
So-
gravity is eliminated. Can he
Eliminated.
dorsiflex against gravity?
Sir, just mild extension was there.
No, that is the thing. You have to grade it. Either it is 2 or 3. Okay.
Sir,
Yes, because you have
2,
also mentioned that there is finger drop.
the
So
finger drop was
and
present.
did you check for sensation in this patient?
Sir, sensation I checked, sensation was paired, so no sensory loss.
Where does the sensory supply goes from the radial nerve, the
Sir,
specific area.
autonomous area is anatomical snuff box.
So that is the exclusive area supplied by the radial nerve. That is, what is the boundary of the snuff box?
Sir, it is extensor carpi radialis longus laterally, then abductor pollicis and extensor carpi radialis brevis laterally.
No,
Sir,
I
the
don't
floor.
think so.
Sir,
No, you have to read this, the boundaries
okay,
of
sir.
the snuff box.
This is in front of the thumb.
Hmm.
This is
Yeah,
the snuff box.
thumb.
Yes.
So extensor, so this is the area where the radial nerve exclusively supplies. Apart from it, it also supplies the part of the dorsum of the hand up to the knuckles. So that part also should be anesthetized in this case. And since the injury is low, you have to check for the other. Since was a vascular injury, did you check for the other nerve functions?
Sir, there was no clawing of hand.
Yeah.
Yeah, other nerves are
Huh.
what? Median and
Ulnar and
median,
median.
ulnar.
So for
there
median,
was no
since there was a brachial artery injury and the nerves, that is the median and ulnar nerve, it travels in the flexor compartment of the arm. So it is quite probable that they also have suffered from an injury. So how did you rule out the radial, the ulnar and the median nerve are spared? Why do you tell that?
Sir, in classically, sir, in median nerve injury, there will be loss of thinner remnants function, like the patient cannot oppose the thumb against other fingers that was present, and the patient was able to flex the wrist to full. So
You
there
can
was
make a
no
fist.
clawing of hand. Sir, make the fist, and there was no
Okay.
clawing noted.
There was no
And
clawing.
sir,
Definitely at 6 months, there should be some clawing if there is ulnar nerve injury.
sir.
So what is one test for ulnar nerve, which you will do and show in the examination that it is
So
normal?
Froment's,
So which muscle does it test?
sir, introscial lumbricals.
No, Froment sign, it tests which nerve, which muscle? It tests the ulnar nerve. So it tests the adductor function of the thumb, that is the adductor pollicis. So what happens in Froment sign?
So the patient won't be able to hold a paper in between the thumb and
And what happens to the thumb?
sir,
Thumb are supposed to
loss
be
of adduction.
extended. Yes. Thumb becomes what?
So the patient will try to flex the thumb and hold it with hold.
Yes, right. So in an attempt to hold the paper or in between the thumb and the radial border of the hand, the index finger, and the patient, in comparison to the normal side, will try to hold that paper or that card by flexing the IP joint of the thumb, because the IP joint flexion is done by the flexor pollicis longus, which is supplied by the median nerve. So since the median nerve is normal, he will flex the thumb, but on the normal side there will be no flexion of the IP joint of the thumb noted. And for the median nerve, which one test will you do to rule out median nerve injury? Which muscle is exclusively supplied by the median nerve in the hand?
Thumb opposition.
Yeah, opposition actually is a combination of movement. When you ask the patient to oppose the thumb against the little finger or the index finger, there is abduction, then there is flexion of the thumb. First there is abduction, then there is flexion, and finally there is pronation of the thumb, because thumb has a carpometacarpal joint which has a very good range of motion. So it is abduction, flexion, and pronation which you are testing together, and all these three are done by three different muscles. So it cannot be exclusively a function of the median nerve. For exclusive function of the median nerve to test it, one test you have to do the pen test. What is the pen test?
You're asked to hold the patient a pen between the tip of.
No, in the pen test, what we do is we ask the patient to place the hand flat with the palm facing upwards on the table. You have to ask the patient both the hands you are examining, and on the affected side, the patient will be unable to abduct the thumb towards the pen. So if you ask the patient to abduct the thumb, you will be able to see that he is unable to abduct it from the plane of the hand. There is plane of the hand. So there are different types of abduction of the thumb. One is the palmar abduction, and another is the radial abduction. There are two types of abduction. So he will be unable to do the radial abduction, since it is in cases of the median nerve injury. So you have to do the pen test, and you also have to feel for the abductor pollicis brevis muscle, which is part of the thenar muscle, against the resistance, that is unable to do it both for and against the resistance. Okay. So since the ulnar and median nerve functions are normal, you have tested the motor function. There are certain sensory territories also. So what is the sensory territory of the median nerve?
Median
In the
nerves
hand.
are in the palmar aspect, median nerve supplies the medial 3.5 fingers, lateral 3.5 fingers.
Okay.
Then
So in
ulnar
the
nerve.
hand, we usually tell it to be radial or ulnar, not
Okay,
medial or lateral. That
okay,
is preferred.
radial 3.5
Radial
fingers,
3.5.
median nerve.
So whole of the thumb, whole of the index, whole of the middle, and the radial
No,
side of the ring finger.
Ring finger. Then
And
rest
the
1.5 ulnar nerve.
yeah, ulnar nerve. So ulnar nerve supplies the ulnar border of the hand, which is very important because we keep our hand usually rest our hand on the surface over the table or over our car steering by the ulnar side of the hand. And how much in the dorsal side does radial and ulnar nerve supply?
So dorsal radial nerve supplies the radial 2.5 fingers. Sir. Radial 2.5 fingers, in which the entire of the thumb it is applying. In rest of the 2 fingers, it is applying up to the PIP joints.
Yes, right. So in the dorsal surface, the nail adjoining areas up to the PIP joint is supplied by the ulnar and the radial median nerve, not the radial nerve.
Yes. Sir.
So do you know why this happens? Can you tell me? So why the dorsal side?
Why the dorsal? So there is a communication between the radial.
No, it is not a very essential question answer to know, but it is related to the embryology of the hand, which you may not read in your level. So next is what are the muscles which are supplied by the radial nerve?
Sir, all the extensors of the wrist.
You can tell from proximal to distal.
Okay,
it is better if you tell
proximally,
from
okay,
proximal.
proximally in the axilla, it gives supply to the triceps, long head and medial head of triceps. Then it also gives a posterior cutaneous nerve of arm. Then in the spiral groove, it gives a branch to the lateral head
triceps. Why is it called triceps?
Because it is having 3 heads, long head,
So what are the 3
and
heads?
lateral heads.
Long, medial, and lateral heads.
Yes. Sir.
So it supplies all the 3 heads.
All the 3 heads.
After how does it come from the axilla to the arm?
Sir, it is posterior to the no, sir, it is through the quadrangular space.
Okay. And then
Then, sir, in the spiral groove, sir, it supplies the triceps lateral head. Then it comes down and supplies the anconeus, extensor carpi radialis longus. Then, sir, brachioradialis.
Supinator.
Then in the intercondylar line, it gives a supinator and it divides into superficial radial branch and deep branch. Deep branch dips into supinator and forms the posterior interosseous nerve, and it goes behind and supplies the extensors of the wrist.
Now, extensors of the wrist is ECRL and ECRB, which it is
Okay, sir.
supplied just above the elbow.
Supplies the extensors.
Extensors of which
Posterior
joints?
joints. Sir,
The metacarpophalangeal joints, MP joints. So, what are the extensors of the MP joints? Which muscle extends the metacarpophalangeal joint?
metacarpophalangeal. Sir, extensor digitorum
Right.
communis.
Extensor digitorum communis slips. So, for the index and the little finger, there is an extra slip
Extensor,
apart from the EDC.
extensor
the name?
indicis and extensor digiti minima.
Right. So, EDM and EIP, extensor indicis proprius. And for the thumb, what are the muscles which goes to the thumb, which is supplied by the
Sir,
radial nerve?
Sir, extensor pollicis, longus and brevis.
Extensor pollicis longus and extensor pollicis brevis. Apart from that, any other?
Sir, abductor. Sir.
Abductor, yes. What is the name of the muscle?
Abductor pollicis longus.
APL. So the boundary of the snuff box is formed by
Sir,
on one
these three
side.
muscles, extensor
Yes.
extensor
All the
carpi
muscles
radialis,
going to all the tendons going to the thumb.
going to the pollicis.
Going to the thumb. That is the pollex. That is abductor pollicis longus and extensor pollicis brevis
And extensor.
on the radial side, and
Okay.
on the ulnar side it is the extensor pollicis longus. This is forming the two boundaries and the wrist joint on the proximal side. So, how can you individually test the muscles in a radial nerve palsy? Like you have tested the wrist joint extension.
Brachioradialis,
Yeah, you have brachioradialis. You told the ECRL, ECRB. That is, patient is unable to extend the wrist by keeping both the hands on the table on the affected side. So,
yes,
can you test the other muscles? How will you test the other muscles?
Sir, extensor indices can be tested separately.
No,
Sir, sorry, sir.
There are extensor complex. Okay. The lumbrical interosseous.
Okay.
Yes. So, as Sir is telling that since there are too many joints like the metacarpophalangeal joints as well as the interphalangeal joints, the long extensor, these are called the long extensors, the extensor digitorum as well as the extensor pollicis, extensor indicis, extensor digiti minimi, these are long extensors. This primarily acts in the metacarpophalangeal joint. So, when we are testing for the extensor function in the hand of the long extensors, we have to test for extension at the MP joint. So, if you ask the patient to flex the fingers and extend it while you are testing the radial nerve, then it will be a wrong test. So, you have to ask the patient to make the hand flat on the table with the palm down, not the palm up, the palm down, and ask him or her to extend the fingers in this extended position because of the IP joints. Because the IP joint extension is done by the which muscles? The interphalangeal. The interossi, that is the lateral band which is formed by the intrinsic
FTP.
muscles of the hand. The intrinsic muscles of the hand, that is the interossei lumbricals. They are the prime extensors of the IP joints through the extensor expansion. Because the tendon ends, the extensor tendon, the rounded tendons becomes flat and it becomes an expanded hood-like structure at the MP joint. Then it proceeds towards the each finger and it is joined by the from the lateral side by the extensor bands coming from the interossei muscles. So you have to test the MP joint extension, not the IP joint extension in cases of radial nerve palsy. Okay.
Okay.
Sir, if you want to
Yeah.
ask anything more.
Yeah, we can start with the primary management. The primary management was they did the radial artery, brachial artery repair and the fracture part.
Yes.
What are the strategy about that? Because patient on presentation has evidence of nerve palsy. So what is the strategy for primary management? There is a convention saying that you delay the nerve repair. What is the current
Sir, in
concept?
this case, I will ask the examinee to tell something about assessment of vascularity. So
Yeah.
one, you have told that you have examined the radial pulse. The
Yes.
radial pulse clinically appears to be less prominent or diminished, felt to be less
Less
palpable than the
compared to the
normal
normal
side.
side. Yes, sir.
So what more test you can do to assess circulation in this patient?
Sir,
Clinical test.
Allen's test.
Yes. So how will you do Allen's test?
Sir, ask the patient to flex the neck towards right side in an
Allen's test
abducted.
is not neck.
Oh, sorry, Allen's. Sir, ask the sorry, sir, sorry. Make the patient to make a fist.
So you will palpate first. You will mark the radial and the ulnar artery.
Yes.
You have to try to feel. You will be able to feel the radial artery against the bone, but the ulnar artery, since it is in the medial side below the tendon, you have to come about 5 centimeter proximal to the wrist crease, that is the distal wrist crease, and you have to feel the ulnar artery also. And keeping all 3 fingers of both hands, you will need both hands to do the Allen's test, your both hands. So you have to feel the radial and ulnar artery, and you have to ask the patient to make successive fists, like flex and open the fingers in rapid succession for about 3 to 5 times. And then you have to occlude, press the radial and the ulnar artery and occlude the circulation to the palm, that is to the hand. Then you have to check that the fingers are blanched, that there is no circulation or the redness or the normal color of the fingers are gone. Then you have to test for the presence of adequate arch. In this case, it should be good because the injury is at much proximal higher level. You have to release the ulnar artery and check that the ulnar artery is perfusing all the fingers, even the thumb, by the change of the color. So what is the normal capillary refill present in the nail bed? What is the satisfactory or normal capillary refill?
Less than 2 seconds.
So it should be brisk or less than 2 seconds. So if it is more than 3 seconds, then your Allen's test is positive. So there is either an anatomical abnormality where the arch, what are the arch present in the hand?
Sir, superficial and deep palmar arch.
Apart from palmar arch, is there a dorsal arch?
So dorsal, sir, venous, sir.
So there is also presence of a dorsal metacarpal arch, because radial artery, while going towards the anatomical snub box, it gives a branch towards the dorsal surface of the hand, which is called the dorsal metacarpal artery. So it also, in a normal hand, there is also presence of a much proximal dorsal metacarpal arch, but Allen's test, you test only the palmar arch, that is the superficial and the deep palmar arch. The superficial palmar arch is formed mainly by which artery, radial or ulnar? So you have to
Sir.
read a little bit about the vascularity of the hand. So in coming back to the discussion, if we are thinking about treating this patient, we have to check for the adequacy of the circulation. I think I'm logged out.
Hello.
Yeah, I think I'm audible, or
Yes, sir. You are audible, sir. But from MR Bangor, sir, we can only see them.
so what, shall we proceed or shall we?
Sir, MR Bangor, can you give a thumbs up if you can hear us? I can see Saha, sir, but their mute is on.
Yeah, you have to unmute yourself. Sir has to unmute.
Okay.
From,
Yes, yes. Yes.
Uh-huh. Yes, sir.
I'm sorry. Yeah, I'm sorry that I think my connection broke.
Yeah, yeah. Now it's
Uh,
okay.
Okay. So in this case, clinically, we have to know that whether the circulation is adequate by doing certain clinical tests like the Allen's test. And sir, while planning the management, since it is 6 months old, and I think clinically it is a recovering nerve injury, we can continue with the present. We can continue with the present management of splintage and physiotherapy for a few more weeks and do a serial uh, electrophysiological test. Since initially he was unable to do anything like extend the wrist, and there was extend the finger at the MP joint, extend the thumb, and since it has improved in last few months gradually, in this case clinically we have to do a serial electrophysiological test maintaining a gap of about 4 to 6 weeks. So if there is no improvement in the electrophysiological tests like the EMG and the NCB, which is corroborated clinically, then we should go ahead with the plan of nerve exploration and repair. Before that, I will be doing a CT angiogram of the repaired site to see for any stenosis or any correctable vascular abnormality which has happened in this case. There has to be development of good collaterals because in any vascular injury where the main vessel or the main supplying artery is injured, there is opening of the choke vessels or the collaterals very rapidly, and usually the hand survives that assault if it is not very proximal or very much with the soft tissues are also injured. In this case, since it is a Gastillo-Anderson 3B fracture of the radial head along with a vascular injury which was repaired, I will do a CT angiogram and take help of vascular colleagues if there is a long segment stenosis. Then planning of vascular repair, re-repair or vascular reconstruction by either autologous graft or by synthetic grafts like the PTFE graft or the Dacron graft. In cases where the graft is traversing the joint,
should you consider
sir, I think I am.
hello?
Yeah, yes, sir. Yes, sir.
Yeah.
Sir, actually, the weather is not good. It is very cloudy. I think that is
Yes.
Yes.
So what I'm saying is, if we are planning for, suppose there is some vascular stenosis which might require some revision. So in that
Yes,
case,
sir.
same time, if there is a residual
Nerve injury.
paralysis persisting, would you address the nerve injury?
Yes, sir. Yes, sir. Definitely.
Yeah.
So
Because
along
already
with
6
the
months.
yes, sir. If we are re-exploring the site of the repair of the vascular injury, we have to do the nerve repair either by end-to-end coaptation. It is better called a coaptation because we are not repairing each fascicle. We are repairing the perineurium or the epineurial repair we are doing. So we have to do a end-to-end coaptation with or without a nerve graft. So radial nerve, this is the question to the examinee. How does it travel from the arm to the forearm?
Sir, initially it was medial, then in the spiral groove, it
Yeah, after it exits the spiral
medial to
groove.
lateral, then in the it pierces the intramuscular septum and comes anterior, and it lies lateral and anterior, lateral to the arm, sir.
So it pierces the intermuscular septum. Before piercing, it supplies the supinator muscle, and
Triceps
then
muscle.
triceps is supplied much earlier. That is much proximal. And then it supplies in the spiral groove. It supplies the brachioradialis, then ECRL, ECRB, and then it before piercing the intermuscular septum, usually it supplies the supinator muscle. And it comes anteriorly. After that, what happens? How does it enter the forearm?
Okay, sir, in the intercondylar line, it divides into superficial and deep branch. The deep branch dips into the supinator and goes behind the interosseous space in interosseous membrane and lies posteriorly. And the superficial branch, sir, lies in between the it lies between the brachioradialis and brachialis.
Brachioradialis and brachialis, that is in the arm.
Yes,
Yes,
sir.
but how does it enter into the forearm?
Sir, in the intercondylar line, sir, it dips into the supinator.
So it passes in
enters
between the two heads of the
two
supinator
heads of the
muscle,
supinator. Sir.
and it pierces the supinator and goes towards the
Posterior
extensor
thumb.
surface of the forearm. Yeah. So after doing that, it gives the sensory branch, that is the radial sensory branch
Superficial
or the
branch.
superficial branch, which is purely sensory, and then it goes into the in between the muscles of the forearm, the extensor carpi ulnaris and the extensor digiti minimi, the ECU and the EDM, and it travels as the posterior interosseous nerve up to the wrist joint. So in this case, since it is a since it is a low radial nerve injury, we have to go and repair the radial nerve. So we have to find the radial nerve. The radial nerve is usually found in between the brachioradialis and the brachialis muscle above the elbow joint. And since the site of the injury is at the elbow joint, the proximal end can be found by dissecting around the lateral intermuscular septum and along the spiral groove to find the proximal end. So if we can bring the two ends without much tension by mobilizing maximum 10 centimeters of the nerve proximally and distally taken together, then an end-to-end coaptation by a non-absorbable 8-0 polypropylene suture has to be done in the elbow in extended position to allow for maximum laxity of the nerve. But if it is not possible, then we have to consider the interpositional nerve grafting. The interpositional nerve grafting is done by taking certain donor nerves. Yeah. So commonly we take the sural nerve. Yes. And one of the principle is not to take a donor nerve from the same extremity. So in this case, we will consider sural nerve as the most important donor nerve for this patient. And we have to take a pre-operative consent for harvesting and taking the donor nerve if required for the repair of the radial nerve. So we can use sutures as well as certain other things like tissue glues, the fibrin glue, in making the repair site less cluttered by the sutures, and it has to be a micro neurosurgical repair or microneural repair. That is, repair has to be done under magnification. Sir, splintage, I think we should discuss
Yes.
something about
Then
splintage.
apart from repair, what are the ancillary treatment? When you done the nerve repair, there should be some ancillary treatment in the post-op period.
Yes, sir.
Yes.
Sir, in the postoperative period, sir, I have read about sir internal splintage.
Yes, so what is what is internal splintage? You tell me.
It is pronator teres to ECRB.
No, these are nerve muscle transfer. You're not talking of muscle transfer. If you have done a nerve repair, you have to splint the limb.
No.
You have to allow rest for the nerve to
Yes.
Elbow in flexion and mid-prone position with wrist extension in 30°.
and then
And
what about you have to keep the muscle active?
sir, after 4 weeks of splintage, we can start mobilization. Initially,
The joint has to be kept supple.
uh,
If you use splinting, you cannot ask the patient to remain everything static.
yes,
There will be some both active and passive movement of the joints.
yes, sir.
So you have to do a splintage, which
How
is
do you monitor in the post-op?
that whether your nerve repair is going okay or whether you are able to get something from your operation. How will you assess the post-operative results apart from the wound and the wound healing part? What is that?
nerve recovery? How do you assess?
Sir, clinically, sir, active mobilization of mobility of the joints.
Before mobility, there will be something coming up, na?
Sir, in sensory now, there will be tinel sign and motor march in case of motor nerves.
Yes, so a progressive tinel sign is what sir is asking. So what is, how do you check for a tinel sign? Suppose that there is a ulnar nerve palsy, how will you check for a tinel sign? Radial nerve also is a mixed nerve, so it has both sensory and motor, like the ulnar nerve and the median nerve. So how will you check for a tinel sign? Suppose there is a
So
ulnar
there
nerve
will be
injury
progressive,
at the wrist.
progressive distal travel of the paresthesia, sir.
So what do you do in tinel sign? How do you clinically test it?
So there will be hyperesthesia in the region of sensory supply of the nerve. So if the nerve is regenerating, this the region of hyperesthesia will be traveling distally.
Okay, so while you have to identify the course of the nerve, suppose the ulnar nerve is found in the medial border of the forearm usually, and you have to, from distal to proximal direction, you have to tap the nerve course, the muscle as well as the nerve course from distal to proximally by successively tapping the nerve course by the palmar surface of the index and the middle finger. The examinee's middle and the index finger, you have to tap it. And you have to ask the patient to point out the area where there is maximum sensibility of the portion which is supplied, of the portion which is supplied by that nerve. So in case of radial nerve, you can do it by tapping it from in this case, from suppose say from mid forearm in the dorsal side and going up to the mid arm level and checking to see if there is an end neuroma. So presence of a tinel sign is the conclusion is there is a neurotmesis, that is a nerve injury, a positive tinel sign. But after your repair, you can use the tinel sign to monitor the clinical improvement of the tinel sign, because the nerve, if we have done an adequate coaptation, then the nerve will progress distally, the repairs will progress distally, and this distal progression, the distal recovery will be about 1 millimeter a day. After your repair, you have to wait for about a month, that is 4 weeks, and after 4 weeks it will progress distally. The distal progression, if you can find by a very careful clinical observation, is one of the signs of a recovering nerve. Apart from that, you have to know about the muscles which are supplied in succession to monitor the motor march which you are telling. That is after it comes to the elbow and becomes
the nerve will start supply. The muscles recovers from proximal to distal.
Yes, the first muscle it supplies is the extensor carpi ulnaris, ECU. So ECU extends the wrist joint and can be felt at the ulnar border of the dorsal surface of the forearm, the extensor carpi ulnaris. And then it supplies the extensor digiti minimi, EDM. So more on the ulnar side, it supplies in the proximal part. So these two muscles, if you can elicit that they are actively extending with gravity or without gravity, that may be one of the clinical signs of recovery. Other than that, the electrophysiological test, as we are discussing, that this may be one of the quantitative tests to assess whether we have a good nerve regeneration or nerve repair. The internal splintage is important in this case because this is a compromised hand and vascular assessment is being done. And maybe vascular repair is also being, we will also have to address. Then only nerve repair should be advised for now in this case. if the nerve repair does not progress, or if there is no adequate results, even after say 3 months and 4 months, and we are continuing the muscle stimulation electrically, which sir was telling, apart from splintage, you have to stimulate the muscles to keep the motor end plates viable, because after a certain duration the motor end plates stops discharging. There is depletion of the neurotransmitters, which may be which is present up to 9 to 12 months, and after 12 months, even after nerve repair, the good nerve repair, the muscle won't be neurotized. So in this very important time of your nerve repair, you have to carefully monitor. If it does not progress, then we should go for internal splintage or tendon transfer. That is tendon transfers for 3 joints. For the first joint, the wrist joint, since the ECRL, ECRB and ECU, the 3 extensors of the wrist joint are not functioning, we have to replace the one of the muscles, that is the ECRB, because the ECRB is stronger muscle and it is more centrally placed. So we choose the ECRB in preference to the ECRL and ECU. And we take the donor muscle, that is the pronator teres, which is supplied by the median nerve. So the pronator teres is taken and transferred. The tendon of the pronator teres is transferred to the tendon of the ECRB to give an extension of the wrist joint. For the EDC, that is the extension of the MP joint, which muscle do we take for tendon transfer?
Flexor carpi ulnar.
Yes, we can take the flexor carpi radialis, the FCR, okay, or the FCU, because there are many different types of tendon transfers. So we take the FCR and we do an end-to-end repair or end-to-side repair with the EDC tendon, that is the extensor digitorum communis tendon. And for the EPL, that is the extensor pollicis longus tendon, we take the PL, that is the palmaris longus tendon, which is supplied by the median nerve or healthy nerve, and give it to the EPL. So I think more or less, sir, we have discussed about the radial nerve injury, and only last one question, that how do you test for the triceps?
Triceps.
Yes.
Sir, ask the patient to extend the elbow joint against resistance.
Yes. So you have to ask the patient to and feel the muscle in the proximal arm or in the mid arm. You have to keep a hand. Just one point I will ask you to just check, because in one of the clinical examination books which I was going through, they specifically told that the shoulder joint has to be in a little bit in an extended position while testing the triceps. So you just check, because in one of the book, Ronald Macri, MCRAE, this is clinical orthopedic examination. In that book, which I found in most of the books, it is told that you ask the patient to extend the elbow joint against resistance. But in that book, it is specifically mentioned that in order to test for triceps function, you have to ask the patient to extend the shoulder joint a little bit from the axis, and then ask the patient to extend the elbow joint from a flex position against resistance. Okay.
Yes.
Okay, sir.
Okay. Okay, Dr.
Okay,
Kash.
Professor. Thank you, sir.
Thank you, sir.
Thank you. Thank you.
Okay.
इसको स्टॉप हो गया हाँ, गया तो है